this anytime they wanted. Let me get back to here so I can. So am I like everybody else? Is it trying to load?
Yeah, I'm trying to pull it up. I had a little bit of trouble. The EHR wouldn't load for me earlier this morning, so I went into the practice manager and it popped right up. And now it looks like it's just slow again.
Well, while we're working on that, I did want to mention actually several resources that we either have available or that I'm going to be working on. First of all, I know Damon already had this, the pocket guide to the DSM-5. Do you guys all have access to that?
Yeah.
Okay. Shannon, do you have a copy of that?
No, I don't think neither Jody or I do.
Okay. And I know, Rosanna, I guess you have it here because you can just come over and get mine if you need it. And then, Bart, do you have a copy of that?
I can see this copy.
Okay. The copy of the DSM-5?
Oh, yes, we have that, yes.
Okay, great. All right. So one of the other things, Damon, I was just talking to Lana about is that we do have a shared drive. And what I would like to do is use that shared drive to put measurements like self-inventory checklists, like for depression or things like that.
Mm-hmm.
And what I'm thinking that you guys could also do, the therapist could add, like if they find an inventory checklist that they like to use, they could also just, I guess, send it to me and I can put it on, or maybe they can put it on themselves. I'm not sure what the limitations would be there, but we could build a shared list, a shared file, so that, if you want a measurement for depression or anxiety or mood disorder, whatever, you could go on there and find one, and then you can use that on your treatment plan. So does that sound like something that would be good for you guys?
I think that would be very useful.
Yes.
Okay.
Yeah, I do too. I've been looking for a few things like that, just kind of fishing around for them.
Okay. The next thing that I'll probably will also put on the shared drive, but that we'll go over the next time that we do this, is I've been promising you guys those cheat sheets for that are based on the DSM-5. Obviously, the pocket guide that Damon gave us has that in there, but what I plan to do is give you something very simplified that you can just print off. If you think, like you said, a person has depression, you can just pull that off. It'll lead you right down there, the questions that you need to ask, and of course, if it fits, then you make the diagnosis, and then you will make your treatment plan fit that. One of the things that we talked about last time that I just want to go over again today is that, if you diagnose depression, then when you get to that goal, you want to be talking about depression. If you got that they're being oppositional and defiant, that should trigger you to ask the questions, do they have ODD? And of course, if they do, then you would make that your another treatment goal. Okay. So yeah, the last thing that I did, I purchased a couple of books, one for a treatment planner and one for progress notes. These resources, I never can pronounce this first guy's name, but I think it's Jongsma, Peterson, McGinnis, and Bruce. These resources have been common for me to have access to in other locations. So obviously I have them here at the Charleston office, and you can't drive down here and look at them, but feel free to call me if you feel stuck on a treatment plan or some type of therapy notes that a specific therapy thing that you're wanting to work on. I can pull these up, go through them, go through the specifics, and give you some very, more detailed information. If you like what I'm giving to you, then, we may look at trying to provide some of those books at each office, but we can talk about that later. Okay. Anybody have any questions about any of that?
Scott, we could also, those inventories that you were talking about, we could have those in our note library on the EHR system.
Okay. Is that like a shared drive? Is that the same thing?
Well, it's just basically where we're pulling up, the notes, like our progress note and everything, the treatment plan and assessment on here. We could actually just build that into the EHR so that they're in this library and people can pull them up and, just include it as part of a patient's chart.
Okay. Well, yeah, that might be even better then, because they could just do the assessment and make it part of the file.
Yep.
Okay.
We can work on that.
All right. So this is kind of going to be. I sent out an email to everybody, and I noticed that Mike also added his part on there. Just a reminder to you guys, like as of right now, I have no treatment plans for Signature. And I know Mike was saying he had no intakes that needed to be signed off on. So I don't know if there's a problem, and if there is, we can talk about that. But if those treatment plans aren't signed, then there's no reimbursement for your work. So it's really important that I sign off on those. Anybody have anything?
I know that I have several that I've done. Like, I don't know if they're all signed off on or not.
Okay.
I guess I'll have to go back through and check and see if either of you have signed off on them.
Yeah, something happened. I had several to sign off, and I think where they were doing some work on the system, they've been lost. James isn't on here, but or is he? Let me see here. No, James isn't on here, but he sent me several to sign. But when I went on there to sign them, it just showed where the person had been checked in and checked out of the, showing up for the treatment plan, but there was no actual treatment plan that had been done for me to sign off on, unless I don't know how to find it. I went over into the patient's chart, and everything I pulled up that said TP, there was no actual treatment plan.
Scott, I had done one yesterday and sent it in.
Okay, well,
what's the name on that? What's the name of that client?
Diamond Miller.
Okay, I'll look into that. Well, let's go through the training, and I'll check on.
Okay.
If anybody can send me a name, just email me the names of some treatment plans that you feel like that you had Scott as a signer on, but he hasn't signed. Send me those names, and I'll try and figure out where they are being deposited.
Okay. So, can anybody tell me on the treatment plan when it needs to be face-to-face? Like, what situations do I have to be involved doing it either by telehealth or face-to-face with the client instead of you just sending it to me for signature? Does anybody know what those are?
Scott, that might be some of the ones that I was talking about.
Okay, so yeah. So major affective disorder, depression, bipolar. I'm just going over this a little bit from last time. Psychosis, any kind of psychotic symptoms, substance use that's not in remission, autism or autism spectrum disorder, and or lower intellectual functioning. Those are the things that we're looking at that I'm going to be involved doing face-to-face. Otherwise, you can send them to me for signature. And we also talked about that you're going to document say that if it is a substance abuse, but they've been in early full remission, you're going to put that in where it says health concerns. We talked about to make sure that you put the review date. I don't know if that's been added on there or not on the treatment plan, but that's also very important to document. When will be your next 90-day review date? It's 90 days, not 6 months. Okay, so
Scott, can I ask a question?
yes, go ahead.
Okay, so but if they have like unspecified depressive disorder, that doesn't count as a major affective disorder, right? Like an unspecified diagnosis, or does it?
Unspecified depression doesn't. If it's unspecified mood, it does.
Oh, okay.
Yeah. Yeah, so that is, if you diagnose unspecified depression, then you don't need a treatment plan. I mean, you don't need me to do a face-to-face.
Right.
Yeah.
What about unspecified anxiety or unspecified bipolar?
Unspecified bipolar, yes. Anxiety, no.
Okay.
Yeah. All right. Sorry. So the things that I want to talk about, we talked about last time in the treatment approach. Let me just kind of go over what I have here for you, and then I'll get to the treatment approach. So I put probably the 3 things that I think you're going to deal with, right? The first, and you can see how I did it on my diagnoses. I put post-traumatic stress disorder for the first one, major depressive disorder for the second one, generalized anxiety disorder for the third one. And then I put for the additional diagnoses, I put things that are, what we would refer to as V codes or Z codes too. So that's where I put mine. Now, I know you all don't do that, and that's fine. I just kind of did it because this way, because it just makes sense to me. Because when I go down and I do my treatment plan later on, it breaks it up more evenly. All right. So you don't have to do it this way, but if you like how how that looks, then feel free to use that kind of method. This what I did was I just kind of made up somebody in my mind that was going through these issues. So I put social maladjustment in there because I figured someone that was, I just said this person was having PTSD. They weren't, they were having trouble getting in, how it goes sometimes people that have these traumas, they go to school and they end up getting teased by their peers because they're going through all these hard times, which is hard to understand, but it does happen. And then even though sometimes kids go through trauma and abuse when they're removed from their parents, they can feel very sad and upset because they've been taken away from their parents. So I just put those other things. I think no, I don't think there's another one, but I thought I added academic problem on there too, but I don't see it. To me, when I put academic problem or educational problem, that V code, I don't always see that as a learning problem because of a learning disorder. It could be a learning problem because of all the issues they've been going through. So a lot of times I'll use that code, if they're getting written up for all kinds of behavioral issues, or if they were making B's and C's and now they're making D's and F's. They're having an academic problem, but it's not due to a learning problem. It's due to the environmental issues that are going on. So, okay, yeah, if you want to scroll on down there just a little bit, Damon. We talked about this last time, but under treatment modalities, you can see that we did, I put in the targeted case management, and then the intake, and then the therapy. On the frequency, I pretty much did it the way everybody is doing it. You can see that I did one evaluation every 6 months, and I think that's what I think that's what the manual says that you can do. I know one of the things, and I'm just pointing this out again, one of the things that Gene would prefer is that I would make some kind of statement saying 4 units every week with completion of therapy for a specific goal, say the depression, or the depression to be covered within reduced, by that 75% or whatever it is within a specific time period. And the more the specific you are, the better that he likes it. So when you get down into the specific short-term goals, if you were saying this goal will be accomplished by such and such a date, I mean, they love that more and more. I'm just telling you to think about it. I'm not saying we got to do it because I think that makes it a lot more complex, and I do not want to make this longer than it has to be. But it's just good to keep in mind that when you're putting down this frequency, that you're also thinking about, how long is it going to take you to get this done? Okay.
Question here.
Yes.
Two questions, actually. So we are, because one of the things I haven't been doing, I haven't been listing the treatment plan there. So we're supposed to list the treatment plan in the modality section?
You're supposed to have the modality section as part of the treatment plan. Is that what you're asking me?
No, like how, okay, no, the assessment I meant. I've not listed the assessment in there before. The HO 31 that you have listed there.
Okay. Go ahead.
I normally don't list that there. Are we supposed to be doing that?
Well, I put it in there. I don't see why you wouldn't, because you could very easily be doing an intake 6 months afterwards, or you could be doing another intake if their situation changes. So, let's say that they are at home right now, and that they're going to be going to foster care placement or be going to a group home and then eventually be putting in foster care. You probably are going to do another intake, maybe, let's say, when they get to a new home in a new county at a new school. You may very well end up doing another intake at that time because all the problems could be changed at that point. It may be more social issues. They may be getting in fights at school. They may be developing depression because of all that. So you could easily do another intake. And that's the kind of thing that, you should be thinking about because if their situation has changed drastically and you're still working on the old goals and diagnoses, there could be new ones that are added, right? So I would put it in there, just the long answer to that question.
Okay.
I do not think anybody else is.
Okay, and another quick question with that for the individual professional counseling, the 004, you have 4 units every week. What is the actual amount that's allotted for the insurance that we take?
Well, it can, if you're doing what's the word I'm looking for? Not focused. If you're doing coordinated care, you can be doing it really by definition, once a week is minimum. I mean, you could be doing it 2 times a week or even 3 times a week. I wouldn't think any more than 3 times a week, but I think that also you have to be careful because I think maybe 60, I forget what the upper limit is. I can let you know about that.
Okay.
Not to interrupt, it is 60 for general Medicaid, I know.
Okay, so what happens after that, Patricia? Do you have to file for additional authorization for services?
Yes, so if it's just like the general Medicaid, that needs the KeyPro auth, it's super easy. You can just go in, I can request an authorization for services, and they will retroactively reimburse. However, with Aetna, they don't backdate. So if any, I mean, certain MCOs, I'm not sure how it is for all of them, but I know Aetna, I think, also has 60, but like, they don't, if you run out and then have to request more, they won't pay for the time between when you ran out and requested more and were hopefully approved. But like general Medicaid will. So I just caution that people be super careful not to run out of units. Like,
These are 15-minute units.
Right. So if you're doing an hour, you've used up 4 right there. And if you're thinking about that, if you're doing therapy twice a week, 60 is not very much.
Yeah, it comes out to about once a week for 12 weeks.
Yeah. So, okay. Yeah. And that's a good question because, you don't want to be doing your work for nothing.
Right.
Scott, I'm sorry, Scott and Damon, when y'all were bringing up, we may need to reevaluate. I've got 3 kids and they keep bumping these kids. It seems like CPS wants to move them or the foster parents give their 10-day notice. Should I just, I've tried to give them like a 2-week kind of adjustment period. Should I do a reevaluation on these kids?
How long have you been working with them?
Probably about 2 months.
Really, at that point, I would just look at if you need to update your treatment plan.
Okay.
If the situation has changed and you've got new problems that weren't there before, especially if you are, anytime you're treating, let's say that, you were treating depression and anxiety and all of a sudden it's very clear cut to you that this kid has PTSD now. And you start treating that, if you've not updated your treatment plan, that's going to, when you turn in your billing, that's going to get kicked back because they're going to say this is not in your treatment plan. So if you've had changes like that, then yeah, you'd want to redo your treatment plan. Now, if it's been, I'm going to say 6 months, and the reason why I'm saying 6 months is because that's what the manual says, but technically, if you've had major changes, it's been 6 months, then, you might consider doing another intake. Basically, the intake, the treatment plan is, okay, I need to tweak this. A new intake is there's been major changes. So that's kind of the way you want to look at it. Major changes, do an intake if it's been 6 months, and minor changes, or treating a new diagnosis, then tweak the treatment plan.
Okay, thank you.
And Mike, I saw you're on here now, so feel free to jump in if you have a different view on things.
Nope, I'm right there with you, Scott.
All right. So treatment. Okay, the thing that we want to look at are the differences between treatment approaches. Primary problem, long-term problem, and then if you'll scroll down there just a tad bit more, short-term objectives, the measurements, and then the therapeutic interventions. These things are all different, and what we don't want is for you to just repeat the same things over and over again. So if you've listed up top, I'm sorry, Damon, if you could go back up, it's a little bit smaller there than, yeah. Okay, so yeah, if you've got client-centered therapy under treatment approaches implemented, then when you get down to therapeutic interventions, you don't want to just put client-centered therapy again. All right. So the difference is when you are at the, I'm sorry, Damon, if you can go back up again just a little bit. I'm kind of swapping back and forth here, but is there any way to make that screen a little bit larger?
Good.
Yeah, if I could get like the, let me see, go up there. Okay, yeah, if I can get the treatment approaches and the therapeutic interventions all in the same area, the same view, that'd be great. If not, I'll just have to ask you to scroll up and down. Okay, yeah, that's good right there. Okay, so I just, I listed these on under treatment approaches. I listed things that I feel at least moderately comfortable with using. You may be comfortable with other things, and I may not be familiar with those. I think I told you last time, transactional analysis. I am really not familiar with that. Another thing that I saw someone list the other day was impact therapy, and I get that it's an eclectic approach to therapy, but beyond that, I don't know much about that. So when I'm reviewing your treatment plan, what I want to see is, let's say that you're doing transactional analysis. If you list that under treatment approaches implemented, then when I go down to therapeutic interventions, I should be able to see types of interventions that you would use that are under transactional analysis. Okay, so the treatment approaches is very broad, where the therapeutic interventions are very specific, and they should be to that specific problem. So for the primary problem, I wrote there, client is experiencing symptoms of PTSD, including intrusive thoughts and flashbacks, cognitive and environmental triggers related to the trauma, trust issues, lack of loving feelings, emotional lability, some dissociative events, loses track of time for short or longer episodes, and hypervigilance. Now, that really should be a reinstatement or a restating of what came out of your intake. So that's why your intake is really important, because it's going to drive your treatment plan. All right. And of course, you might write yours differently than mine, but you just want something in there that says, what's going on with the primary problem. Anybody have any questions about that? Okay. So long-term goals, based on that primary problem of PTSD, client will decrease physical signs and symptoms related to PTSD by 75%. Client will be able to verbally recall the traumatic event with decrease in autonomic and environmental responses by 75%. Client will improve, anyway, there's a whole lot of things there I listed. So where did I get these from? I got these things from the therapeutic approach that I'm going to be using. What are my goals going to be for this person in the big picture? Okay, so let's see. So client will manage and minimize, number 4 there, client will manage and minimize the effects of trauma-related triggers when at home or in the community by 50%. Okay, so you can just hold it right there. So my short-term goal then is going to show how I'm going to address my long-term goal. So I may have that, and I think I listed that in there in my short-term objective about the client will participate in 2 social or community activities, over the next, I don't remember what I put, but maybe it was 6 months, or maybe over the next full term or something like that. So that, and of course, when I'm working on that in my therapy note, I'm going to list that short-term objective, and I'm going to say, Joey signed up for Little League basketball, for this, for this coming season. Okay, so that is meeting one of those goals. Now, not only am I going to talk about that, but I'm also going to work on, how does he think of, from CBT? How does he think about that? How does he feel about that? What are his behaviors? Is he withdrawn? Is he interacting? Does he feel like it's, you know, not worth it? How's he responding to the therapy of that? That's all going to be in the note. But when what I'm trying to say to you, and you can definitely look over all this, and if you have more questions about this treatment plan and how it flows, you can let me know. But your diagnosis should be the primary thing. The primary problem should be from the diagnosis. The long-term goal should be, what is my long-term objective? I want this person to, you know, decrease in symptoms of PTSD that I mentioned under my primary problem by 75%, 60%, whatever. And then my short-term goal should be, you know, more of my therapeutic interventions of how I'm going to do that. So that when I get to my therapeutic interventions, you know, they're going to be very specific. In other words, if I would look at the notes, or if Mike would look at the notes, or if Gene would look at the notes, he'd be able to see that, okay, I should be able to look at these notes and see where Scott did some psychoeducation on PTSD and its effects, okay? Now, that's not a percentage measurement, but it is subjective. You know, if I didn't go in there and educate and document in my treatment notes PTSD to this client, then I would have not used that therapeutic intervention. Let's see, referral for psychotropic medication. I don't think a lot of people do this, but you know, if you see, like Sandy, this child you're working with right now, if they haven't been referred, they most likely need referred for a psychiatric evaluation. So, you know, that's going to be part of your job as a therapist, making sure that referral is done, making sure they're checking on the efficacy of the treatment. Is the medication doing what it should be doing? Are there side effects? Making sure they're taking it the way they're supposed to. Some people think that, you know, you take a pill for depression when you feel depressed, and if you're not depressed that day, you don't take your medicine. And of course, we know that's not right. So, you know, educating the client on things like that. Relaxation training, obviously that is a therapeutic intervention. Positive self-talk, positive psychology. And of course, positive psychology could also be listed under a treatment approach. So, I mean, you can see I've got some overlap even in this treatment plan myself. What a narrative therapy, which is really good for PTSD. So my thing is this, you know, this is just what I did based on what I know. You're going to put in things based on what you know. Somebody sent me something the other day, and they listed a therapy, and I just responded, and I didn't, you know, they didn't say that they thought I was being a smart aleck, and believe me, I'm never trying to be a smart aleck, but when you write things, sometimes they sound differently than when you talk to somebody in person. Anyway, I asked them if they were an expert in that. And of course, I'm not an expert in all these things that I'm listing here, but I do use them. Client-centered therapy obviously is not a thing that I know a lot about, but you know, I do use especially the unconditional positive regard approach when I'm working with a new client. So that's very important. And so, you know, I listed that. I could just list it as empathy under CBT, but, you know, I just like the way it's worded. So I made it part of how I look at things and how I do things. But anyway, I'm not expecting you to be an expert on everything that you list, but I am expecting that you feel comfortable with whatever type of therapeutic intervention it is that you're using. And, you know, I'm totally okay with if you're trying a new intervention. I mean, that's great. You know, try something new, see how it works for you. And you know, put that in your treatment plan, you know, that you're using that. So does anybody have any questions about that, especially my main goal in doing this training today is to try to give you an idea of the differences between what I'm looking for or what Mike is looking for when we're talking about treatment approaches, primary problem, long-term goal, short-term goal, and therapeutic interventions. All right. Well, I know I talked a whole lot there, so if you do have questions later on, feel free to to ask me about it. And Mike, I know you're doing training after this, so you might want to add things onto that. The self-report measurement. Can you click on that little box there, Damon, where it says I added this in myself because. For me, I'm going to be doing self-report, but also I've just put scoring, but the inventory checklist, I may very well, CBT is really big on inventory checklists. So, every time you meet, if you were buying the actual protocols, it would be very expensive. But if you've got some type of measure in CBT, you really, want to get some type of measurement of how they are doing with their depression, how they're doing with their anxiety, how they're doing with their mood issues, and you want to track that. So I put self-report and scoring, but the thing about it is that you can tweak this. I just typed that in myself. That's not a typical option that you'll see there. So I think that's a good thing.
And this is a multiple choice drop down type box, so you can select more than one on this.
Oh, okay. Well, I think I tried that, but maybe I didn't. So, if you could do that, then that's what I should have done. I just should have clicked on.
Well, and you can also do what you did, Scott, which is just hit the little green square here and add whatever item, add however you want to measure it. You can just create that, and it'll always appear in the list. But yeah, this is a multiple choice box.
Okay. Okay, so the secondary problem I just put because of the PTSD, the client developed some depression triggered by the trauma, but also this person my make-believe person has had some depression because of their lack of they no longer have family support and the issues they're having at school. Again, the long-term, short-term goals are for that. You can scroll on down to the third issue there. I made that about anxiety, partly related to the PTSD and partly related to the things that they're worried about, and that they've generalized their fears over PTSD to fears about anything that's going to come and harm and hurt them. The case management goals, that was already in there. I like that, so I left it there. I don't know who put that in there, but I am, those kind of things are really new to me as far as treatment planning, because I worked in private practice, so I didn't change anything there. And maybe Mike will have more to add or adjust to that. But the last two things here, client response, and then all the way back up to the top, which was barriers. You don't have to scroll back up there, but barriers to treatment. Make sure that you think about that. I know people will put in there something like client help pick out the goals or something real short like that. And to me, what we're looking for is, did they agree with the goals? Did they agree with the interventions? Are they concerned that they're not going to be able to do this? Do they feel overwhelmed about this? Or do they feel like, yeah, this is going to be, perfectly what they need, and they feel like that if they get these goals, they're going to have that big improvement in their life, which is what they wanted. That's kind of what I feel like we want in a situation like this. And then the barriers to treatment. A lot of times I see that blank. But if typical barriers that I see are people they're not able to communicate. They don't feel like they have a problem. They don't have any support. Poor motivation. You might have poor motivation because the courts have referred them because of truancy, and they don't want to be in school. So all this work that you're going to be doing with them, they don't even want to be in school. So why do they want to improve so they can go back to school? So that could be a huge barrier for treatment. This treatment plan that I put on here took me quite a while to do. But now that I have this here, when I get somebody else, I would pull many of these same things. I'm going to tweak them, obviously. I don't want to just copy and paste every single thing every single time, but I would tweak it. And obviously, the next time that I did one of these, it would be a whole lot shorter. I'm here doing training on, the quality part of it. But when you're out there doing the work, we want you to be able to get it done as quickly as possible so that you are able to go and work with your next client and bill for your next service. I mean, for you, out there doing your job day to day, you don't want to spend 2 hours doing a treatment plan. So, use this one, but tweak it. You may want to do different types of therapy, obviously, from what I'm doing. So, but the goal of this and the goal of today's training is just to give you an idea of what I'm looking for. And this is probably, this is, in my opinion, this is a lot. So you may not come near to having this much, but we still want to see the quality of thought. Really is what it is. How much thought have you put into meeting this person's problems? I had something else I wanted to say based on that, but I lost it. So, anybody have any questions?
I would definitely encourage everyone to use these little green add item situations. Like Scott said, I mean, we know that we're going to be dealing with a lot of PTSD, and having a long-term goal related to symptoms of PTSD, I believe ought to be things that are in our this drop-down list. Now, you're not, as Scott said, you're not just going to pull stuff out verbatim. You may want to change it. You may be dealing with a client who you realize, you're not going to be able to reduce these symptoms by 75% in this time frame. So you may want to change it from 75 to 50%. But I think having, we could, a year from now, the way that I would imagine this forum looks is that it really is a treatment plan builder in and of itself, where you're identifying problems and you're looking back at some long-term goals and short-term objectives that have been utilized with prior clients that are in this drop-down list that you could select from and say, well, this is pretty close to what I want. But I need to change it a little bit for this particular client because this doesn't actually fit the assessment. But having these things in the drop-down list over time is really going to speed up the work that we're doing. So I would use these things maybe when you're thinking about a short-term objective and you're wondering, should this be on our item list? Maybe you can call Scott or email Scott and say, hey, I'm thinking about putting this short-term objective in our item list. And we can go in and delete bad ones if we find bad ones in there. But if you think you have a good one that's going to be something that you're going to use for multiple clients, then put it in the list.
Yeah. Yeah, and I definitely want to look more into, doing this shared type thing too. And in my mind, I keep thinking a shared drive, but I need to think more of it, this advanced MD. So I'll have to put some more thought into that, and when I add those things, I'll keep you updated. And this, I just want to re-emphasize. I don't even know if I finished my story about about being an expert. I think I did. Yeah, I'm not looking for you to be an expert on everything, just to be comfortable with that specific intervention that you're using from that specific type of therapy.
Just keep in mind that that the phrase comfort level can be a little bit subjective, and everything that Scott is saying, I agree with completely. Just make sure that you can evidence base what it is you are specifically stating that you are doing with the client, and that you have a working knowledge of it and the intent is there. So just to reiterate what Scott was saying.
Right. That's what, right. From start to finish, your primary problem, long-term, short-term, and your therapeutic intervention, and then your treatment note. It all should just flow together, and it should be very obvious that, okay, the treatment plan will help you get your session to focus on what you want to focus on for that session.
Absolutely. Lots of times when we find ourselves engaged in discussions about treatment plans, we have a tendency to simply focus on the treatment plan being what it is or what the outcome for the client is going to be. And although that is 100% true, also keep in mind that one of the things that I have experienced is, especially with younger clinicians, is that it's not uncommon at times for even seasoned clinicians. It's not uncommon for times to be where you find yourself feeling somewhat lost in a session, having difficulty determining what directions to go. And just keep that in mind also when you're formulating and writing the treatment plans, because the treatment plans can, in all actuality, help not just guide the client to the desired outcome, but it can also assist you, the clinician, in staying focused and remaining intact and knowing a direction. So just sort of keep that in mind as well.
Hey, Pam, I see you're on here. I think we need to, I'm not sure, I guess maybe that's Damon, but maybe with Mike's input, we need to figure out where we want to put which, I think it's good. I think we need to have a section on there that says we have completed this treatment plan, and maybe even put the date that it's closed out. Will that pretty much get you where you're wanting to be?
Yes.
Okay.
So run that by me again. What are we looking for?
Just something. It would probably be under each. Well, I don't know. I guess we could have it up there at the top too. Just anywhere for each primary problem. I would say maybe the primary problem. What are you thinking, Pam? Are you thinking for each goal or each problem or each diagnosis? I mean, what were you thinking of?
Well, what we could look at, excuse me, is when we have completed a goal.
Okay.
Typically, when you're looking at goals, you can put like a criteria of success that you're looking for in 3 months. And if it's closed and you met that goal in 3 months, then we can say we've met that goal and we can move on to the next one.
Yeah, see, and Mike might feel like I can see where we would need to tweak it, but I like it in the fact that it gets to that point of it shows that we're thinking about how long we're going to be working on, how long we project that it's going to take us to get that done. And I think that the audit, that will help with the audit. I'm just not sure how to do that. I mean,
Well, you know what I think you could do is so basically if you're updating the treatment plan, what you would want to do is, and you could do this with the client or you could just do this as a separate treatment plan note. But I believe if you were to go into Mickey's file here and schedule another treatment plan meeting, Scott, so let's say you did this again, and you went in, all of this information should be on there. So if you pull up the treatment plan, everything that you've written in here should be on the new treatment plan. And then you could make the adjustment to, like, say, the goal. Let's say that long-term goal 1 has been met. So let's say tomorrow you schedule a treatment plan meeting for tomorrow. When you go to the note, all this information is going to be on that note. You would adjust the long-term goal saying that goal number 1 has been met. And then when you go to a progress note a week later, that progress note will indicate that the primary long-term goal number 1 has been met. I think you would just reschedule another treatment team meeting, make the change on the new note, and that would flow through to the next progress note. We may have to practice
Yeah,
that.
that sounds good. Typically what I do with my summaries and my objectives, when I'm looking at a criteria of success, I look at, do I need to continue it after they bet there's 75%, let's say, and we say after 75%, they maintain this for at least 3 consecutive months, give you a timeline to work with it. So do I want to continue this? Do I want to revise it? Do I want to discontinue this goal, or just plainly has the goal been achieved and we're not going to look at it again?
Right. Does anybody have a treatment plan review coming up in the next week or so? Because we could actually look at this in real time. Anybody?
I mean, this is something that could be looked at in a 6 months review. But if you have a criteria of success within 3 months, which typically, that's when change of behavior occurs.
Yeah.
If you're consistent.
Yeah, anybody that's on here now that has, the next time you do a treatment plan review, the next time you're going to look at a treatment plan, I mean, I'm sure somebody has to have some coming up at some point. Send me a note so I can kind of watch how this note transforms as you make adjustments to the treatment plan. I'm pretty sure that just using your old treatment plan, making the changes on a scheduled appointment will transfer into your continuing progress notes. So just,
something else I was thinking about, if you're looking, you're working with your client within this period of, let's say, 6 months for another review. Okay, so they met the goal within 3 months. You cannot change a goal without a treatment plan, but I would say you could modify what their expectations of criteria success. So instead of 75%, you can bump it up to 100% and still maintain that goal. Does that make sense?
it does to me.
Okay.
So you're saying we would just
That way you
basically
don't have to.
we're just increasing it by 25% to meet the 100%.
Yes. Yes.
Okay.
And so that you wouldn't have to change the treatment plan. You wouldn't have to change a goal because you can't change goals between meetings. So to avoid an audit issue, you can just modify what your criteria of success would be so you can maintain that goal and then revisit the goal with the treatment team and say, okay, they've met it up to this point. And then you got to, what you want to try to do is have 3 consecutive months of maintaining that same percentage.
Works for me. I'm pretty much done unless anybody has any questions.
Well, so in the last email message, we basically decided that we would spend as much time as we needed to on treatment planning, and then Mike was going to take over with just any clinical queries, case-specific stuff. So Mike is here, so I'm just going to continue to record. If you guys want to ask Mike any questions, he's all yours. Thanks a lot, Scott. That was a good training.
Yep. All right.
Appreciate it, Scott.
Yep.
Good stuff, guys. Good training. I popped in, I guess it was about 10 till. I thoroughly enjoyed it, and everything that I heard was more than relevant. Anybody have any questions or anything that's going on?
Mike, did you have anything that you wanted to share, like in terms of presenting any information or?
Well, what I had planned was, I know the last time that we were on, we had started discussing the case with Kim, and is Kim, are you with us today?
I don't think she joined us this afternoon, this morning.
Okay. Well, in all actuality, I don't have, because that's what I had planned on doing, was seeing if I could have you make Kim the presenter and Kim pull up her mental health assessment, and we could start to look at that case that she had initiated the last time when we ran out of time.
Right.
So that's what I had planned. But if Kim's not with us today, so the floor is open to anybody who might have any questions. If not, I can take off talking, but I didn't have anything specific other than just wanted to follow up with Kim.
Well, you still have an audience.
Okay. So I'm just going to sort of pick up where Scott was on this, but I'm going to add a little bit of a different flair to it. Looking at these primary problems and then the long-term goals and the short-term objectives and the therapeutic interventions. Since the bulk of the clinicians here at Homebase have a tendency to utilize that cognitive behavioral or a CBT type of approach, let's say that CBT is identified as being your treatment approach. Then underneath therapeutic interventions, what type of specific CBT interventions would we have a tendency to want to see under cognitive behavioral treatment approaches? What are some examples of specific interventions for CBT, guys?
I think the modeling and role modeling.
Okay, modeling and role modeling. Okay, what else? What other specific interventions are linked to being CBT interventions? If we're gonna go by, like, let's say Beck or Mnuchin or following that ABC type format, what are some of the specific interventions or strategies that are looked upon as being interventions? Step one, of course, would be identifying what? Activating events, causal factors associated with the primary problem. If it's PTSD or if it's depression, identifying what the potential causal factors are, or what might be some events that may have a tendency to promote surfacing some of those symptoms or presentations. So that would be specific or therapeutic interventions. Might be just simply identifying activating events or triggers associated with presentations of the primary problem. Another specific therapeutic intervention associated with the CBT format could be values clarification or belief system clarifications as it relates to that person's schema or that person's logic and reasoning processes associated with that causal factor or the incident or situation. You know, there's quite a few like CBT techniques or tools that are known to be linked with CBT. You know, some of those examples are maintaining a journal or the use of certain cognitive restructuring type skills. When I say cognitive restructuring, guys, what am I talking about? What would be an example of cognitive restructuring? Okay, first off, when I'm talking about cognitive restructuring, basically what I'm saying is you are going to offer assistance with your client in helping them be able to challenge or confront their potential harmful or distorted belief systems, and helping them to be able to identify fault where fault exists, and assisting them in being able to identify factual-based data that contradicts what their distorted cognitions are. You know, other examples could be exposure and response prevention. That could be a specific therapeutic intervention that you're utilizing if, in fact, you identify CBT as one of your treatment approaches. That would be assisting the client through dialogue as to being able to identify what may be provoking certain types of behaviors associated with their depression or their PTSD. Cognitive distortions or confronting cognitive distortions, which is similar to cognitive restructuring. It's a component of it. But helping the client to gain self-awareness or insight as it relates to what those distortions are and how those distortions are directly impacting their abilities to function in a negative way. You know, all of these could be examples of specific therapeutic interventions that, again, are linked back to that treatment approach. And it's very possible that you may have certain therapeutic interventions that you identify and utilize not only in your short-term goal, but you may also utilize those same specific therapeutic interventions towards the long-term goal as well. It's going to be solely contingent upon the patient or the client and how they present in front of you. And we've got some room here in regards to you guys being innovative and creative as it relates to these treatment plans, and I'm sure Scott would agree. As long as it can be tied back and linked, you know, just thinking, you know, discussions that we have all had as it relates to some of the data presented. You know, I think it was several weeks ago we had a discussion about Socratic dialogue. Well, that could be a therapeutic intervention utilized underneath CBT, excuse me. And it could be linked to either the short term or the long term. Other examples might be based off of what we had talked about previously. I know several weeks ago we talked about behavioral theory and how each behavior has a specific function. And that function could either be social or automatic. And let's say that, and just using Shandy as an example, let's say that one of the things that Shandy is wanting to do is identify origins of those maladaptive behaviors of one of his child clients. Well, under the treatment approach, Shandy could identify behavioral theory, and then under the specific intervention, he could list identification of behavioral functions or origins behind the behavior, and then also list implementation of the FAST tool, the tool that I had forwarded out to you guys several weeks ago. You know, I guess from my standpoint, we went over several things that we could actually utilize within our treatment plans based on the data that Scott had formulated and the process of what we are implementing here. So, and again, guys, I'm not just available, and some of you have accessed me more here in the past couple of weeks, and I think that's great, but don't just think of me as being here for these trainings. I mean, you guys call me, email me, do whatever you feel like you need to do in terms of staffing cases, or even if it comes to just maybe trying to find the right wording for what it is you have identified that you feel needs to occur, but maybe not know exactly how to frame it up. You know, feel free to give me a call, because there's a lot of stuff here that we have been talking about that is more than applicable, not just when you're sitting in front of the patient, but also when you are trying to formulate these treatment plans to put together an appropriate course of action. Questions, guys? Anybody have anything they'd like to pose or present or statements with respect to clinical interventions?
Quiet crew today.
Yeah, it's a quiet crew. But
Questions up for Scott.
hey, that happens. I fully understand that. No problem. I just want y'all guys to know, and again, I know you have a couple times, Shandy, and I know Pam, we've corresponded about a couple of things and whatnot, but you know, if there's questions, let's talk about it. But one of the things is sort of a sidebar. I'm going to shift over since it's a quiet crew today. One of the things I want to make sure that you guys are doing is when you are completing those mental health assessments or those intakes, those mental health assessments, and you are before you hit the save button on those things, make sure that on every one of those that you're doing, that you are identifying Mike Yeager as a required signer or reviewer on those mental health assessments. If you fail to put me on there, then there is no way that I'm going to know that I need to be reviewing and signing off on that mental health assessment unless you specifically email me or call me and tell me that, hey, you need to read this. But guess what, guys? Even if you do that, and I go into Advanced MD and I do the patient search and I pull up the mental health assessment, I still can't sign it. You need to make sure that you put me on there as a signer. You got it? Because I'm under the impression right now that there's some mental health assessments that I need to be reviewing and signing off on that I have not reviewed or signed off on, and it's because I'm not listed by you guys. And
I've actually put your name on my mental health assessments, and then your name has disappeared.
Can you tell me the name of that one?
You can do any of the 3 cases I have: Angle, Bowman, and Cosner.
Schulte, Angle, Schultz.
And I have to check all mine too, because I think there's some of mine maybe too, but I have to go back and check them.
Is Angle Schultz who you're talking about?
Phoenix Angle, the one that we worked on the first.
The name rings a bell, but honestly, I
He's the young man that you told me to roll out.
I got it here. Hang on.
Autism.
Damon, would we need to just maybe go back and look at our clients and make sure that they are signed by Scott? And would that be easier than y'all have to go through all the clients to make sure they've been signed?
I think that's a good idea. So, Shandy, I just pulled up Diamond Miller, and you have it set up right. Scott should be able to sign it.
Okay, good.
But it's not. But he hasn't signed it, which is interesting.
Well, I just done it yesterday.
Okay. Well, he's saying he's not seeing anything. I'm looking at Phoenix Angle right now, and pulling up that note. Mike, your name is on this to sign, but you haven't signed it.
Yeah, like when I go into advanced CPA, I click on that little oil filter. Well, I click on the my signature or the ones I need to sign. I click on that, and then I go to the little oil filter thing, and I click on that, and I scroll down, and I click on all that I need to sign, and then a listing comes up.
Hang on, I'm going to make you the presenter, Mike. I want to take a look at what you're looking at.
Hang on a second. I'm going to minimize this for a second and open up my advanced CPA. Sometimes it takes me a little. Sometimes it takes me a while to.
Because you are listed as a signer on this assessment, but it hasn't been signed by you yet.
Damon, none of mine have.
Been
And
signed?
when I put Scott as the treatment plan signer too, he disappears.
Okay, let's take a look at what Mike's looking at when we pull it up. There's probably just.
I'm pretty sure mine's the same one. But I have to double check.
Hang on one second, guys. Trying to move this stuff around so I can get to the login button. Oh. I think I went on the wrong one. Well, let me move it back over. Well, it's not going to let me in here. Hang on a second. It's going through now. All right. Okay. See, right now I'm showing nothing unsigned.
Go down,
Right.
go down and click on your notes thing. Under Health Watcher, it says notes.
Okay. I have zero showing.
Go to the filter, the little thing that looks like an oil cap. Yeah, click on there. And I need to sign. Hit apply.
Nothing.
That's weird.
Normally, what would happen is, you see this right here, Damon, the unsigned?
Mm-hmm.
Like, several weeks ago, there would always be numbers in there. And I click on unsigned.
Mm-hmm.
Then I would go in here to the filter and do what we just did. And I would click apply, and a list would come up.
Mm-hmm.
But the list that was coming up was the same ones over and over and over again.
Okay. I'm going to get with Advanced MD as soon as we're done meeting, and I'll see if I can sort this out.
Yes, because I know y'all got I think the last one that I done was maybe the first to last week, and I'm trying to remember the name of it, but I know there's more. That's why I shot you that email.
Hover over that number to Mike and see what happens next to the filter. Next to the filter, hover over the 2.
Closure letter, referral letter, consent forms.
Scroll up a little bit. Huh. There's that other angle when it's not on there. Hit the filter again for a second. And then go filtered by I need to sign. All right, try my turn to sign. Okay, hit apply. I'll go to I need to sign.
Should he try to take off the last 2 weeks thing? Because I know mine and Jody's will be older than 2 weeks.
Yeah, do that. Go to filter again. And then unclick last 2 weeks.
No!
There we go.
Review by, staff. That's my note.
So there's an assessment. Well, that's there's a whole bunch of assessments that need to be reviewed.
Yeah, let's click on this one.
The Hayden McDonald one's the one we, of course, talked about.
Okay, so we found them.
Okay, so all right, I'm with you guys. Sorry, it kept coming up 0. It kept coming up 0, and I did not see that.
Well, I guess because of those dates, it's just pushing them outside of that date bracket. So
I will get on these ASAP.
all right, I'll let Scott know also. I'm gonna go down.
I'm sure that's probably what he's doing as well.
Yeah, that's what I would think.
Good deal. Yeah, but I just, anyway, when I was unsigned, I'd still go in, click the filter, but yep, sounds good. All right, guys, anybody have any other questions or anything?
Damon, and Mike, even we could see, or I know I could see the unsigned here, because I know one day I just logged on and it was dropped down to nothing.
You mean on your dashboard, Shandy?
Yeah.
Okay, well then, so Mike will take care of his assessments. I'll get with Spalding and then, and see if we can find all the treatment plans that need to be signed by him. And then if there are still some left over, then we'll put out a notice to everybody to let us know what names are still unsigned.
Guys, today's Monday. I will have all of these completed within the next 72 hours.
All right.
Thank you.
Thanks,
Wonderful.
Mike.
No, thank you all.
All right, everybody. We'll talk to you later.
Thanks.
Bye.
See y'all. Have a good week.
Goodbye.